I'm sorry this is all quite a lot at the end of the day. I'm just going to present the results from London, and also was asked to present the results from Warsaw, who are collaborators. I couldn't get a picture of the hospital in Warsaw, but ours is ugly enough. Theirs is actually almost as ugly. And myself and Christos helped put the data together for London, and Jaroslav Chikla from the Civil Service Hospital in Warsaw. You know, civil servants always get a bad deal, but they get their own hospital in Poland. Why do we treat? Well, the aim obviously is to control patient symptoms. Obviously we can go for cure, we can, but most of the time we're trying to control tumour growth. And this picture is not an accident. This is our base jumping patient who felt so well after his treatment he went base jumping. Unfortunately, he opened his parachute a little bit late on the last jump and broke his leg, but that wasn't my fault. This is our simple to understand algorithm when we decide what to treat. Now, it looks a little bit complex, but I think it's the same basic principles that we've been going through. If you can cure the patient with surgery, we do so. If not, we look at, if it's foregut, we've got a high Ki-67, they tend to go to chemotherapy first. If it's midgut, then we would consider radionuclide therapy fairly early on. But in all our patients, we don't actually treat, or within our protocol, we're not allowed to treat until there's evidence of progressive disease or symptoms are not controlled by things like somatostatin. Patients with just stable disease are not eligible for treatment under our plan. We've seen this before, so I'm not going to go over that again. We got 114 patients who had at least 2 cycles. 83 patients have had 3 cycles of octreotate. So it's the same peptide as the lutate, but the same isotope as the octreotate. It's all very complex, I know. But it's basically we use octreotate because it has a slightly better stickability to the tumour. You can see we have a very similar distribution of primary sites as seen with other tumours. We have got a few high-grade tumours treated. These are patients who've had progressive disease despite having chemotherapy, but are octreotide positive or gallium-68 dotatate positive. All our patients could only be treated if they show evidence of aggressive disease, despite previous treatment, wherever that is relevant. Obviously, they had to have positivity, or where they had significant symptoms and were failing somatostatin therapy. Like everybody else, we use amino acid infusions, and we're still stuck with using radiological response in terms of PR or CR. This is a classical patient of ours that we've treated. You can see the positivity on Octrescan. We've seen all this before. And here we have also gallium-68 dotatate PET. This is a patient who was only just positive on Octrescan, but was very positive on the gallium-68 dotatate PET, as this patient went on for therapy. We also used a questionnaire system. We had a simple tick box visual analog scale that's given to all our patients in their follow-up, which actually seems fairly simple, but actually works quite nicely. And we've been using this. And 73% of our patients, for example, had a good response to symptoms such as flushing or diarrhea. 84% of the Warsaw patients, but I will remind you the Warsaw patients did have the questionnaire in Polish, not in English. Radiological response, and this is some work that was presented in our group in ASCO last year, and showed that if you just look at RECIST criteria, very few partial responses, but a big group of disease stability of 78%. We didn't use the MR, the minimal response criteria in the other 2 papers. What we have done is looked at the results of our results compared to a series of other studies. And if you're looking just at response rate, you can see that depending on, if you really look down, there's probably not a lot of difference in terms of response rate between the yttrium-based products and the lutetium, with the exception of landrotide, which really wasn't very good at all. The studies aren't entirely comparable because obviously some patients were put in with disease stability and some with progressive disease, but on average we get a 20 to 30 partial response rate, 1 or 2% complete response, and disease stability in the best studies of around about 70 to 75%. So only about 20% of patients fail the treatment at most. This is our progression-free survival from our group after 3 cycles of yttrium dotatate, meaning that the mean time to progression of 36 months and median of 41 months. Again, remembering these patients went into the study with progressive disease, so they're a slightly different group than those groups of treated patients with stable disease and progressive disease. And this is overall survival. We haven't got to our median overall survival yet. The mean is 39 months, but you can see it's tracking that 55% of our patients have survived, and we haven't had any more deaths in the last 2 months, so we still haven't got to our median, but when we get there it will be at least 5 years, which I think, considering we have patients with progressive disease, some which have failed chemotherapy, is not a bad result. Just to finish off, this is the results from the Polish group, and they looked, again, they had a very similar group of patients. They were using exactly the same protocol as we were, bringing patients in with only progressive disease, but they're slightly better organised at getting the results out. So they've got theirs published in the Annals of Oncology last month, and they had 72% of patients with a good disease stability, and they had 6 patients with partial response, and again the number of patients with progressive disease was just under 20%. Now what they did actually find, this is their looking at their survival, progression-free survival and overall survival, with a median progression-free survival of around about 26 months, but overall median survival of just around about 60 months, about the 5 years, the same as us. Again, patients going in are patients who have got progressive disease. And I've shown you this one before, but again, it really confirms what happens on CT is really not that important. If you don't have progressive disease, it doesn't really matter if the tumour doesn't shrink. Your chance of surviving is still as good as those where the tumours shrink. And the problem is that CT is a really bad way of measuring what happens with these tumours. And I see Eric nodding, and I'm sure Sandy, if he's woken up from his Louvre visit, he's nodding too. Because CT measures the wrong thing. Because it only looks at the outside border of the tumour, and they often core out from inside, so you can't measure that. And this is just from one of the Polish patients, just showing uptake of somatostatin and a good response to 3 treatments of the yttrium-90 treatment. Now I just want to spend about a minute on this one if I can, because this is actually a really important graph, and I showed this last year in Winnipeg. So those who are in Winnipeg can fall asleep. Those who weren't in Winnipeg, don't fall asleep, because this is a really important message. Because when you get radionuclide therapy and you go back to see a doctor and they say the tumour hasn't shrunk more than 25%, you might be depressed. Please don't be depressed, because something very interesting happens. If you look at the bottom, there's a set of CT scans. One is before therapy, one is 6 months after the last treatment, and the third one is 12 months after treatment. Can you see that without any treatment the tumour starts to disappear away? And it was hidden a little bit in the Uppsala data as well. I noticed a line saying that some of the patients had a late response, and I think, Eric, you showed that as well. So what actually happens, as long as you don't get tumour progression, your tumours can actually shrink many months or even years after initial treatment, and we've seen the same with MIBG. And the top graphs are what we call waterfall graphs, and what they show is the change in the size of the tumour, and that dotted line along the bottom there is what the radiologists call a partial response. So here we are 6 weeks after treatment, and you'll notice that only a couple of patients have got there, and the rest, though they've shrunk a little bit, haven't actually gone down all the way below the line. But if you notice, without any further treatment, at 6 months the tumours have shrunk even further. All right? And quite a lot of them have now crossed the line. So I think one of the things you have to be aware of is that when we're doing radionuclide therapy, the CT isn't everything. In fact, probably the best predictor is just asking the patient how they feel. Patients who have an improvement in their symptoms tend to live a lot longer than those that don't. So unless your tumour makes your symptoms worse, the treatment makes your symptoms worse, or your CT shows your tumour is growing, then you're probably doing very well. Just the last bit is on toxicity. And this is just a little bit of work that we've just started to do, looking at renal toxicity and bone marrow toxicity. And this is compared to the published data from Eric. And I think the difference is that we probably recorded a higher percentage of renal toxicity with the yttrium-90, and there's good physiological reasons for that. So we need a few more numbers to be certain of these figures, but certainly the efficacy seems similar, but possibly some slightly more toxicity with the Y-90. So I think the question is not really one or the other, but where you can get treated and how you can get treated in a proper system. And we look forward to the day when also people in North America, which is the last continent that can get Y-90 or lutetium therapy. The South Americans have got it. They started it in Bogota now, and they started it in Bangladesh, and they're doing well in India. So come on, guys, you just got to get this done. Thank you very much.